So good morning, everyone. Thank you very much for joining this webinar of patients and doctors webinar, which is a new series of webinar that we have planned. And the first of them is today in the National or International Tinnitus Awareness Week 2024. And we have several presentations prepared for you, and we're going to start them right away. So I'm going to share my screen with you for my presentation. And the panel members, please feel free to turn off your videos and cameras and mute yourself. And I will introduce you after this presentation, before each person's presentation. So my talk is about a multidisciplinary approach for management of misophonia, tinnitus, and hyperacusis. So what is multidisciplinary approach? Multidisciplinary means involving several different professionals or specialists in assessment and management of a particular disorder. And that is the theme for this particular presentation. And we try to have presentation from a multidisciplinary team in this webinar for you, so you get a better understanding of this term in practical terms. So before I start talking about a multidisciplinary approach, give you a quick definitions of the conditions that we are dealing with. Misophonia is when people become sensitive to certain type of noise, and these noises do not need to be very loud, very even quiet sounds, like sounds made by mouth noises, eating, breathing, clicking sounds, sniffing, coughing. This type of sounds can become very annoying and producing a lot of anger and anxiety if the person has misophonia. And obviously, if these significantly impact on their life, then this will be considered as clinical misophonia. Misophonia is different from another condition, which is called hyperacusis. And hyperacusis is when people perceive certain sounds, such as domestic noise or noise in public places, as too loud or even painful. And so people who have hyperacusis, they complain about the loudness of the sounds, and that impacts have a bodily sensation, whether in the ears or head in the body, but it is related to the loudness of the sound. But that is different from misophonia, which the actual type of sounds are mainly certain type of sounds are mainly bothersome. Tinnitus is a disorder that is regularly perceiving constant or intermittent sounds, such as a ringing sound, buzzing noise, or a combination of these sounds that last more than 5 minutes without any external or internal sound source, and has a significant impact on the life of the person. And if a person hears sounds without any external sounds, even if it is a constant sound, but if it doesn't bother them, if it doesn't impact on their life, this, although it is tinnitus, but it doesn't classify as tinnitus disorder. And in the presentations that we are giving in this morning, we focus on when the condition becomes a disorder, a clinical problem that the person needs to seek help for it. So what is the treatment that is available for these conditions? The specialized version of cognitive behavior therapy has shown to be effective in reducing distress caused by tinnitus or certain sounds in the cases of hyperacusis and misophonia. Unlike general CBT methods, the strategies that are used in a specialized CBT program are fine-tuned so they can focus on the distress caused by tinnitus or by the noises in the case of hyperacusis and misophonia. And this is different from a general CBT that you might need to have for anxiety or depression and so on. Sometimes people may need to have CBT for several different conditions because these formulate the problems in different manners. And sometimes people can have one psychotherapy intervention and apply those skills to other problems as well. So these are all depending on the individual circumstances and the treatment protocols that they learn. I do not talk about the actual interventions. Today we have Patricia Pugh and Joanna Barker, who are our senior audiologists and specialists in tinnitus, hyperacusis, and misophonia rehabilitation. They will give you some details about how does CBT, what is the mechanics of a CBT program, and what is it that the patients have to learn during these sessions. So do people need anything more than CBT? This is the critical aspect of the multidisciplinary approach. And it depends, really. Sometimes people can become very depressed, or they may have other underlying psychological disorders, and on top of it, they may experience tinnitus or hyperacusis or misophonia. Therefore, it could be very difficult for them to engage in a CBT program because there is an underlying depression or anxiety disorder or personality disorder that might exist, and that can hamper their progress in a specialist CBT program, which only focuses on tinnitus or hyperacusis or misophonia. And that is why it is important to have that multidisciplinary team. Here we have Dr. Fiona Thornton. She's a clinical psychologist. And after we assess patients, and if they have signs of symptoms of other psychological disorders, then she'll have to reassess them and see whether they need a separate intervention in addition to their CBT for tinnitus or hyperacusis or misophonia. And sometimes people may not have any underlying anxiety or depression or personality disorder and so on, but because of the impact of the condition on them, they feel not very motivated, or they don't feel ready for engaging in a CBT program. And because to do the CBT, you need to be prepared to change your way of thinking and change your behaviors. And these are very big topics of its own, and is not easy to achieve. There are certain prerequisites for a change in behavior and change in the way that you think, that you need to have to be able to engage in that change. For example, you need to acknowledge that the change is needed. You need to feel that you have the desire to make that change happen. You need to feel confidence that you can make the change if you decide to do so, and so on. So for this reason, many people might need support from professionals other than people who do specialized CBT, such as health psychologists. And health psychologists in our team focus on exactly that, focus on preparing patients to engage in a CBT program, and also to support them throughout this program, making sure that they engage with this process and change the behaviors that they need to change, and they are prepared and feel confident that they can use the CBT techniques. So, and also there are sometimes specifically in children with misophonia and hyperacusis, who may also have other diagnoses such as autistic spectrum, ADHD, and so on, or learning difficulties. This can also be in adults as well. And engaging in a CBT program might become even a more challenge for this population. And, we need to have extra helps. And occupational therapists can actually help with that because they have a lot of strategies helping with people on autistic spectrum, as well as ADHD and so on, to engage with life activities and be able to manage their satisfying life. And our occupational therapists, Sherry and Tana, help with that. And today we have Sherry here who can talk about OT intervention specifically for children with noise sensitivity and perhaps a comorbid disorder such as ASD. What about education? We have done times and times again surveys asking our patients that what was the most important thing that you felt it was helping you in managing your tinnitus, hyperacusis, or misophonia. And usually education is among the top 3 most helpful things that people name because they can understand. When they can understand their condition better, it makes it for them easier to want to actually learn how to cope with it as opposed to wanting to avoid it or doing other activities. So we have educational sessions with neuroscientists and researchers who can basically translate the latest scientific understanding of the neuroscience of tinnitus, hyperacusis, and misophonia to simple language that people can understand. Why is it exactly that they hear tinnitus? Why is it exactly that the loud noises sound louder to them than to other people? And why is it exactly that they can't they be super focused on a breathing sound or a chewing noise, while other people can't really even notice those sounds? So these are education sessions, which is, and Dr. Mercedes Erfanian is here today. She can talk about misophonia education and the behind the scene of those sessions of what should happen for these presentations to be able to be communicated to the patients. In addition to support that patients get from professionals, it's also very important to have a continuous support from people who actually know about the treatment and between the sessions can provide additional help to patients in case if they do not know what is it exactly that they need to do their assignments and so on. Today we have Becky who will be talking about patient support sessions. And supervision is a very important concept in modern psychology, and because the interventions that we do are very much psychological interventions, the therapist needs to get ongoing supervision from supervisors who can help them to provide the best care for their patients. Research is, of course, another topic that we are very interested about, and you can, whether it is with scientists around the world or even training the next generation of researchers by supporting the students from many different countries. If you want to read more about our research, you can see our website, and there's a section for research. You can follow that. What about self-help? And self-help is a cost-effective way to help patients to deal with their tinnitus, hyperacusis, and misophonia. And it has been recommended by National Institute for Excellence in Health, the NICE guideline, and we have a self-help program, a guided self-help program. And Evelyn, my colleague, will talk about how does this work. I also encourage you to visit our website for a wide range of events which we have organized for patients as well as for professionals. Of note is the Sound of art competition for misophonia, tinnitus, and hyperacusis, which is open to anyone who like to take part, and the London workshop for CBT for tinnitus, hyperacusis, and misophonia in April. That is for audiologists or psychologists who like to specialize in this field. Also, I encourage you to visit our website and sign up for these monthly webinars on misophonia research and recovery. And so I stop here, and I invite Trish to do her presentation on what is audiologist delivered CBT, and give us some sort of an understanding of what happens when a patient is doing this program.
Okay, so I'll just share my screen here. There we go. So thank you very much for the introduction, Hashir, and I'm really pleased to be able to share this case study with you this morning. So David was a 28-year-old physiotherapist when he first contacted the clinic, and he found us after searching online for help with his sudden onset of tinnitus 2 weeks previously. Now, initially, David hadn't been overly concerned about the tinnitus, but as the days progressed, he found it increasingly difficult to ignore, to the point where he was constantly tracking it and his negative thoughts about it began to escalate. So he explained to me that he'd started to forecast what his future with tinnitus would look like. He found himself asking, when I have kids, how will I be a good dad with tinnitus? And when I'm working, how will I do my job well with tinnitus? And he found himself stuck in this constant cycle of stress and increasingly obtrusive tinnitus. So he sought help from his GP, confident that the GP would find a problem and solve it for him. So when the GP reported that the ears were healthy and there was nothing more for him to do, David's panic increased. He then made an appointment with an audiologist, and while waiting for this appointment, David's thoughts escalated to catastrophic levels. He started to think that if the tinnitus continued like this, he wouldn't be able to live with it, and he might commit suicide. The audiologist issued behind-the-ear white noise generators to reduce the obtrusiveness of the tinnitus. And initially, David liked the white noise, but then he started to have negative thoughts and concerns about the white noise generators. Did they mean he'd always have some kind of sound to deal with? The thoughts escalated further to the point where David began to research how to kill himself. He explained that this was more of an act of desperation rather than a means to form a plan. Unfortunately, he confided in his family members who supported him in contacting a suicide prevention helpline, and he also got back in touch with the GP, who gave him some appropriate medication, which David felt reduced his anxiety enough that he was able to gain some clarity around his thoughts. And it's at this point David found us. So as part of our initial assessment, we took an in-depth history. David described a sudden onset of bilateral tinnitus while sitting at home watching TV 2 weeks previously. It was slightly louder in the right ear and perceived as a high-pitched ringing sound. There was no obvious cause for the tinnitus. There was no history of ear or hearing-related issues, and the audiogram was within normal limits. There was no history of mental health issues prior to the tinnitus, although David did admit to being a generally anxious person and as having low self-esteem. As mentioned previously, David became extremely anxious after the onset of the tinnitus and was prescribed Valium by the GP. He'd also been referred to a psychologist for additional mental health support. There was no history of insomnia prior to the tinnitus onset. Since having tinnitus, David struggled to get a restful night's sleep and had started to use white noise in his bedroom to distract himself from the tinnitus. There was no other medical history. David was otherwise physically fit and well, but he was on sick leave from work due to the increase in anxiety and his tinnitus. thankfully, David decided to sign up to the rehabilitation program. So our first job when we started therapy was to create a customized model illustrating David's tinnitus distress. So the purpose here is to get a thorough understanding of the connections between the bodily sensations, emotions, behaviors, and thoughts David experienced when he heard the tinnitus or noticed he was distressed by it. We're able to identify his initial emotional and physical reaction to the tinnitus, behaviors he employed to avoid the tinnitus, and the automatic thoughts he had about the tinnitus. We identified how his emotional reaction and behaviors escalated in response to these automatic thoughts, and how this in turn led to a list of more evaluative thoughts as he started to ask himself, what does all this mean to me? And you can see from the diagram here, the list of more evaluative thoughts was highly emotive. Some of them were extremely difficult to deal with, and so led to increased levels of anxiety and distress, which in turn fed the vicious cycle of emotional arousal, hypervigilance to the tinnitus, and negative thoughts. And while this task was difficult for David to complete, it allowed him the chance to identify which parts of this vicious cycle we were going to be able to change with the CBT. In order to challenge and modify the thoughts, we created a list of avoidance behaviors that David employed to stop him thinking about the tinnitus. The actual list was longer than this, but I've included a few of his most significant behaviors here. This process also allowed David to really think about the fear leading to each behavior. What did he think would happen if he didn't do it? We then identified how difficult each of these behaviors would be to stop. While we were completing this exposure menu, David shared with me that the exercise revealed to him how much energy he'd been putting into avoiding the tinnitus. So in his own words, the exposure menu exercise was an epiphany. There are a few exercises we used to challenge avoidance behaviors and negative thoughts over the course of the program, but I'm just going to show you one for the purpose of this case study today, and that's the SELL exercise. So SELL stands for stop the avoidance, expose yourself to the tinnitus, and learn from it. It's important to clarify that the exposure element is planned with the patient so that while it's challenging, it's also achievable. The purpose of the SELL exercise is to allow the patient to challenge their negative thoughts and improve their tolerance for the tinnitus and for any negative emotions that come up. So in designing the SELL, we have 4 columns. In the first column, what behavior are we going to challenge? The second column, what problems do we think will occur if the avoidance behavior stops? And in the third column, what do we predict the severity of those problems is going to be? Lastly, what actually happened when the person was exposed to the tinnitus. So David had been examining what he'd learned about his avoidance behaviors during the process of the exposure menu. So by the time we got to the first SELL exercise, he was highly motivated to start challenging his fears and thoughts he had about the tinnitus. So we tackled reading first, which was the lowest difficulty item on the exposure menu. This allowed David to build his confidence in his ability to challenge his thoughts and expose himself to the tinnitus as he was learning how to complete the SELL process. So column 1, we set the exercise, remembering that it needs to be achievable. So David felt he could read for at least 30 minutes a day. He anticipated that it'd be difficult, but that he could do it. In column 2, he identified the problems he thought he would face as being an increase in frustration, an inability to absorb any of the information he was reading, and an increase in the tinnitus itself. So specifically, he wouldn't be able to ignore it. Finally, he predicted the severity of each of those problems as a percentage while acknowledging what the worst case scenario would be. Then he went away for a week and he completed the exercise. And what we could see is that when David carried out the exercise, most of his scores or actual level of difficulty were less than predicted. So even though there were days when the scores increased, so day 6 in particular, By challenging his thoughts and examining the entire week in this way, David was able to conclude, firstly, he was able to engage in reading even with tinnitus. Secondly, an underlying fear of failure had been stopping him from trying to read. And thirdly, when his tinnitus was very obtrusive, it seemed to be related to feeling tired rather than tinnitus being the primary difficulty or obstacle. So throughout the program, we repeated this cell process another 6 times, each time making it slightly more difficult and choosing different items from the exposure menu. So in David's case, we worked through most of the items, eventually challenging his use of white noise generators during the day and his use of white noise bedtime. The exercises carried out over the program took David through a process of recognizing and challenging his thoughts about the tinnitus, discovering what was true about the tinnitus and about life, and identifying where his thoughts might have become distorted. And these new tools allowed him to modify his negative thoughts and form counterstatements, of which we have a few examples here in the list of NATs and PATs. So while we refer to the list of counterstatements as PATs, the positive automatic thoughts, it's important to realize that CBT is not about positive thinking, it's more about realistic and rational thinking, which can in turn make us feel and think more positively. So for example, the first negative automatic thought, if I don't get enough sleep, I can't function and it'll set me up for a bad coming week. So we challenged this with evidence gathered during one of our exercises and with David's own knowledge about his life observed from a more rational standpoint. And the resulting counterstatement reads, I can function, sleep is important, but I'm getting enough. I still manage if I'm feeling tired one day. Now, once created, the counterstatement needs to be committed to memory, so that in a moment of distress, so for example, when David is laying in bed, getting frustrated because he's listening to the tinnitus and not falling to sleep, he can recognize the negative automatic thought, and instead of having the follow-on emotional reaction and the next negative thought, he can easily bring to mind the counterstatement related to bedtime, which he knows to be true and rational because he's gathered the evidence to support it himself. And in this way, the vicious cycle gets broken. As well as talking to David about his experience and what it meant to him, we carried out some standardized questionnaires to better understand the extent at which tinnitus affected his life. So the questionnaires were Tinnitus Impact Questionnaire, the Hyperacusis Impact Questionnaire, and the Sound Sensitivity Symptoms Questionnaire. So the questionnaires ask how often the patient has experienced certain symptoms as a result of the tinnitus, hyperacusis, or sound sensitivity over a 2-week period. So these are carried out at assessment, midway, and at the end of the treatment. For this slide, I've just included the initial and final scores. We can see that the Tinnitus Impact Questionnaire reduced from a moderate impact to no impact, and the Hyperacusis and Sound Sensitivity Questionnaires, although they didn't reach clinically significant levels at assessment, there was still a slight score there. But these two were reduced to 0 by the time we got to the final appointment. Another aspect we measure at assessment and throughout the program is a person's confidence in managing their tinnitus. And we do this using another questionnaire developed using the principles of motivational interviewing, 4C tinnitus, so called because it measures 4 aspects of confidence in managing tinnitus. And we can see from the slide here, at assessment, David scored 0%, so no confidence at all in managing his tinnitus. Midway through the treatment, this had increased to 68%, and by the final session, David scored 100%, so a high level of confidence in managing his tinnitus. At his final appointment, David rated his tinnitus as being a 1.5 out of 10. He'd returned to work full-time and was reducing his anti-anxiety medication with the support of his GP. Furthermore, he felt confident in discussing his tinnitus with others, whereas previously he was consumed with anxiety at the very thought of this. He explained that while he noticed his tinnitus every day, it had no impact at all. And in fact, the most significant tinnitus moment for him recently, receiving the email from me when I reminded him it was time to arrange the final appointment. At our first meeting, David was very focused on why he'd experienced the sudden onset of tinnitus. By the time we had our final meeting, David still didn't know why, but he was so confident in managing his tinnitus, he realized he didn't care either. His final words to me were that he believed his experience with tinnitus, as traumatic as it was, may have been one of the better things to have happened to him, as the work he was required to do to change the way he thought benefited him in multiple ways, with his ability in creating counter statements feeling so natural and so automatic, he wasn't even consciously aware he was doing it. But overall, an excellent outcome for our patient, David. Thank you very much for listening.
Thank you very much, Trish, for your fantastic presentation. And so I encourage everyone to just post your questions as we go. And at the end of the webinar, we allocated half an hour for Q&A. So you don't have to wait until then to post your questions. You can post your questions right away, so you don't forget them. And so in Trish's presentation, you learned how a session for a person with tinnitus, an adult, might look like. And but what about for a child, and perhaps with a different disorder? Now we have Joanna, who is going to talk about. I don't say it, Joanna. You can introduce the presentation yourself much better than I can do.
Thank you, Hashir. So I am going to be discussing with you today a case study on a child. If I do mute my microphone, it's because I have a cough at the moment, which is something that we have to be aware of when we're treating patients who have misophonia and hyperacusis, because it can we can actually trigger our patients on occasion. So this is something that I'm aware of when I am online with a patient. So I am an audiologist. I specialise in tinnitus, hyperacusis and misophonia, and I deliver CBT via video call for Hashir's Tinnitus Clinic. The programme I deliver consists of 14 sessions, 10 weekly sessions, and for the last 4 spaced out to support patients further in their journey managing their condition. I'll be sharing with you today a case study on a patient I saw last year who had a successful journey with CBT. Dottie was 12 at the start of treatment. She lives with her parents and her brother on a houseboat, which became relevant later in treatment. Dottie was attending school and undertaking entrance exams for grammar school. Dottie is a very active preteen, taking part in many sports, dance lessons and productions, and other extracurricular activities. Her medical history was good, no health complaints. Dottie wasn't taking any medication, has never seen an ENT specialist or audiologist, and has never complained of anything hearing or ear related. Dottie had no complaints of tinnitus or hyperacusis. Her main complaint was that of misophonia. Her triggers were chewing, eating sounds, and mumbling, but mainly related from Dad. Later in treatment, this also moved to her brother on occasion. In our assessment appointment, Dottie explained to me that when she hears a trigger sound, she feels irritated, angry, and frustrated. Her physical reactions are to put her hands over her ears, fidgeting, which includes scratching her hands and playing with her fingers. Dottie felt that this creates some level of distraction for her and something different for her brain to focus on. If the sounds are really bad, then Dottie will leave the room. Often this happens when the family are eating together at the dining table, and Dottie struggles to manage her dad's eating sounds. Dottie tells me she will leave the table to go to the toilet. This time allows her some space away from the sound to calm down before returning to finish her dinner. Dad, who attended the assessment appointment with Dottie, commented that Dottie leaving the table is more of a problem if she's particularly stressed or tired. Dottie finds when the family are out for dinner or having a takeaway, her triggers are more manageable. She feels that this is because it's a treat and this helps her to keep her distracted. Dottie reports that she struggles more if a sound is muffled and therefore prefers to sit nearer to Dad so that the sound is louder. She doesn't like to hear Dad's voice talking when she is in her bedroom, and Dad is downstairs as this makes the sound more muffled. Dad has worked with people who deliver CBT and so has some knowledge on this and was keen for Dottie to try CBT. Dad understandably doesn't like to see Dottie suffer, and both Dad and Dottie would like to be able to share meals as a family without this stress. Along with the clinical interview, we use a series of psychometric tools to assess the symptoms of misophonia, any comorbid condition, and the impact of misophonia on the patient's life. From the answers to the assessment, I recommended a specialised programme of CBT for misophonia, which Dottie and her family decided to go ahead with. In my first session, I like to gather more in-depth information about the patient's life, how their misophonia affects them every day. By using motivational interviewing techniques, I can understand the impact of misophonia in greater detail. Mum attended all appointments going forward with Dottie. We initially discussed the situations and experiences that Dottie has problems with, including struggles when they go on holiday. When Dottie and her family went on holiday, because Dottie was spending more time with Dad than usual, she was struggling to stay at the dinner table. This meant Dottie doesn't want to go on holiday with the family anymore. We can see here how misophonia has a ripple effect from the patient to their loved ones. Mum notes that it can be difficult to hold important conversations with Dad because if Daisy is in another room, she perceives the sound as a mumble, and therefore this triggers her. This results in Dottie interrupting the conversation, and Mum and Dad often have to stop talking. During treatment, we create the formulation, as you saw in Trish's presentation as well, which is represented by the diagram. This is a model where we explore in more depth what happens at each stage when a patient is triggered. This formulation is the basis of the rest of the work that we do. Here, we explore the initial reaction to the trigger. This is made up of the patient's emotions, which for Dottie was irritation and annoyance. The physical sensations the patient experiences, in this case, fidgeting and feeling squirmy, and the behaviours they rely on to try and manage the trigger, which Dottie said was stamping her feet, shouting, and leaving the table. The thought section is the first time we look at the negative automatic thoughts that the patient has. This is the first thing that the patient thinks about when they have a trigger. Once a patient has had these thoughts, their reaction may change, either during the trigger or immediately after. This is recorded as their follow-on reaction. For Dottie, she found she would feel frustrated and often upset after a trigger. She would feel uncomfortable and her behaviours were trying to get Mum to distract her. The evaluative thoughts section requires the patient to start thinking deeper into thoughts about misophonia. For most patients, especially children, this is the first time they would have consciously considered the thought process that they have when triggered. And at first, they may not be able to think past, I want this noise to stop. As a CBT practitioner, it is our role to guide them and ask appropriate questions to explore these areas and start to look at core beliefs surrounding their misophonia. For Dottie, these were, I feel like I am missing out and I don't want my relationship with my dad to get worse. The first intervention we used in treatment for this patient was a SEL. This stands for Stop, Expose and Learn, and was based on the list that we created with Dottie, her exposure list. This is a list of behaviours and rituals a patient uses as they believe they help them manage their trigger sounds. When we create this list, we ask the patient why they do these behaviours, what it is that they fear will happen if they aren't able to use this technique. We then ask them how to score how difficult it would be for them to stop this behaviour. When starting the SEL, we typically go with one of the lowest scoring behaviours or the patient preference. In this case, Dottie was asked to stop covering her ears when she hears a trigger sound. She predicted her negative automatic thoughts that may happen when she does the experiment, looking at what will happen to the sound, how she will feel, and what will happen in terms of her function or social interaction. The patient then predicts how difficult this will be, and when the patient does the cell, they can then score how difficult it actually was. This is a learning experiment about what happens when they expose themselves to the sound, also understanding that exposing themselves to the sound will increase their tolerance. This isn't a pass or fail. We can learn from we can see from Dottie's cell that she scored lower than predicted at each attempt, although by doing the experiment, it made her realise she uses this behaviour more often than she originally had thought. Each week, the patient will complete a new cell, focusing on a new behaviour. We'll learn more about the cognitive behavioural process, so they understand why and how CBT works. And they'll also complete a diary which looks at the event that have happened in the week. The patient fills out these thoughts and emotions about triggering events. Using Socratic questioning, we can evaluate this thinking to establish Dottie's core beliefs. Dottie worked through each of her negative automatic thoughts, created counter statements for these. These are short sentences that she can then use to counteract her negative thought and neutralize the negative emotion. This slide shows some of the negative thoughts and counter statements that Dottie created, such as I feel different. She created the statement, I am unique, which made her feel more confident with her negative thoughts. From the diary, we identified a core belief that life is unfair living with misophonia. We used a continuum exercise to allow us to explore this in more detail. Dottie scored herself at a 4, closer to life is 100% unfair. We then looked at what someone's life would look like if life was 100% unfair, and what someone's life would look like if it was 100% fair. Dottie felt she identified with the characteristics of 100% life is fair and moved her score to a 7. We then created the counter statement of her thought, life is unfair, which left Dottie feeling upset and sad. She is now able to use, you may not have it the best with misophonia, but there are lots of other good things in my life. And this leaves her feeling happier and more content. The diary is a great learning tool for CBT, but it also allows us to recognize patterns in behaviors. For example, the diary highlighted that Dottie struggles more with triggers in the morning when she is particularly stressed because she is unorganized. Dottie adapted her morning routine and found her triggers in the morning became much more manageable. Dottie found an increased awareness and better ownership of her misophonia made life a lot better. Dottie also highlighted to Mum that she often experiences the same reaction to trigger sounds that Dottie has. And this has made Mum think back to when she was Dottie's age and realises she has probably dealt with misophonia herself over the years as well. Sorry. Dottie has learned that if she is particularly triggered by Dad, avoiding him doesn't help. And so Dottie has begun to seek out her father to engage with him socially and finds that this helps manage her triggers better. Between Mum and Dottie, they realise that due to the acoustics of living on a houseboat, you're never really able to escape noise. And so going to her room for some time to calm down doesn't work, as it is not an escape for Dottie as the sound becomes more muffled. On these occasions, Dottie now goes to her mum's office, which is a smaller boat attached to their houseboat. Dottie was engaged throughout treatment and made considerable improvement in managing her misophonia. At the end of treatment, we used the same psychometric tools to assess the patient's impact of misophonia on their life. Dottie's score showed increased confidence in her management skills and symptoms, which affected her much less than they did at the start of treatment. Mum tells me she has noticed a huge difference in Dottie due to treatment. We both recognise the drive that she had in the work that we did, despite also dealing with busy school life, exams, busy social life, and everything else that comes with being an adolescent. Mum tells me that they have now been able to book a holiday away, as Dottie feels confident about going on holiday and feels confident about sharing meals as a family together again. Dottie has a better understanding of how to move forward in life with her misophonia, using the tools that she has learned and adapting the techniques as her life and circumstances change. Thank you for listening.
Thank you very much, Joanna. Thank you. And so we now heard about the CBT intervention for for a child with misophonia. And as you can imagine, it can be quite hard for children as well as adults to go through all of these program of CBT methodology and learn how to deal with their problem on a consistent and regular basis. And that's why a multidisciplinary team can be very helpful in helping patients. And Becky is here now to talk about patient support sessions, that what she actually can help to a patient who's doing CBT. Becky, before you start, we have actually an interesting question who's posted by Amy asking when you are doing the experiments in CBT, what if the actual fear that they have come true, and what is their prediction is actually 100% correct, and how can that actually be helpful or managed in a CBT session? Thank you, Amy, for your question, and we are going to discuss that in the Q&A session. Becky, please go ahead with your presentation.
Okay, wonderful. Let me just minimize this. Hello, everyone. And yes, as Hashir said, there's often a need for extra support with our treatment plans. And so I'm going to tell you all about our support sessions. I am a patient support officer with Hashir International, and I will explain what our support sessions entail, how they help our patients, and why they're such an important part of our treatment plans. There we go. So what is a support session? Our support sessions are one-to-one 30-minute chats that are conducted on a video call, so they are in the comfort of their own home. And each session is based on the benefits of peer support. It is a very relaxed discussion. It doesn't necessarily involve learning new techniques or digging deep into the tools of CBT. They will learn that with their specialist audiologist. Instead, we offer our experience of the treatment plan, of the program, and our knowledge, and sometimes simply a listening ear to have a conversation about how they're feeling with their progress. So together we discuss their personal relationship with misophonia, hyperacusis, or tinnitus, how they're finding the CBT sessions so far. And I mean, from my experience, the conversation kind of can really go in many different places from that point, many different directions. And so I'll be giving some examples of those directions in my presentation. Support sessions, they are, as our slide says, they are part of our treatment program. So by enrolling in a treatment plan, it includes 3 sessions, and that's whether it's a treatment plan for misophonia, tinnitus, or hyperacusis. And we try and schedule those support sessions to be roughly towards the beginning, the middle, and at the end of the treatment plan. They are very, like I say, informal and open. And crucially, in my personal role as a support officer, I have an additional perspective that I'm able to offer to each of the patients. I have misophonia, and having gone through the CBT treatment myself, I've now been managing my misophonia effectively for about 2 years. So I have that experience kind of under my belt. So when we're speaking, I can really relate to their experience and they can relate to mine. And provide a really high level of understanding, which brings me to what our kind of objectives are of our support sessions. So what do we want them to offer for each patient that's involved? So approaching challenges together. They're an opportunity to tackle a difficult situation together. Perhaps the patient is struggling with one of the tools they've learned, or they're uncertain about a technique that they've been taught. I have experience and advice to offer, both through my knowledge and through the other support officers' knowledge of the treatment plans, and we can work through it together, kind of add that additional help if it's needed. And of course, if there is ever a deeper gap in understanding, we can speak to their dedicated therapist and make sure that that gap is filled in the next session, and provide that kind of feedback between ourselves, making sure that we're really across exactly what that patient needs specifically. Communication is a big part of that. Making sure all patients are heard is really important. Feeling heard and understood can be so crucial when you're experiencing something that can separate you from other people, make you feel alienated. In several cases, I have been told I'm the first person who also has misophonia that a patient has spoken to, or if they haven't got misophonia, I'm the first person who can directly relate to some of the everyday sensations and experiences and feelings that come with misophonia, hyperacusis, and tinnitus. It's incredibly difficult trying to describe or justify the feelings of misophonia, hyperacusis, or tinnitus to a loved one if you don't quite have the words, especially when you're perhaps feeling triggered and overwhelmed. Finding the right way to communicate that is so difficult, especially when there can be blame or shame involved if a trigger is directed at, a loved one, a friend, or a partner. So I found during our support sessions, patients feel it's quite refreshing and reassuring to talk to someone like myself or the other support officers who are understanding, but kind of neutral. We can appreciate those feelings and thoughts, but without relationship strings attached, or that kind of strained feeling that can sometimes come when that anxiety and fear is related to someone so close to you. And even if they're not, just to touch on that, like I said, I have misophonia myself, but even if they're not experiencing misophonia specifically, there is significant overlap across how CBT is used to also manage tinnitus and hyperacusis. And I've had some incredibly rewarding chats with people who are learning to manage tinnitus, for example, even though it's not something I've directly experienced. In the context of CBT, there are so many similarities in attitude, in the effort that you must put in the techniques that you can use. And lastly, in the objectives, we can provide context and explanation to their families, parents, partners, especially when we're speaking to children and young patients. There are often questions that a loved one might love to ask the person who is experiencing tinnitus, misophonia, or hyperacusis. Those questions can feel quite urgent, but you don't want to cause more stress or offense or pain or make them feel awkward. That's completely understandable. So in support sessions, there's also an opportunity for us to speak to parents and partners with the hope of explaining what could be happening in their loved one's mind, providing our own experiences as kind of context or food for thought, so they can kind of process what their loved one is going through, which can be very, very painful to witness as an outsider. Sorry, there we go. And so, yeah, the next slide, as we've seen with Trish and Joanna, during today's event, we'll be hearing other members of our team kind of presenting case studies. And so I thought it'd be useful to look through my own notes and dig into some of the real scenarios where our support sessions have played a crucial role. So on the left here, I'm struggling to come up with counter statements. What kind of ones did you use?
Becky?
Yes.
Can I just interrupt? I think the slide doesn't show properly, at least on my screen. If you go back and forward again, maybe it solves the... So now this is the support session objectives. So this one, we don't... Do you have 3 boxes here, or is it only 2?
There are 3, but I can see them on my screen, so maybe I'll just say them out loud and then explain why.
Because we only see 2 of them. And
then...
Oh,
okay. Thank you for letting me know.
Or maybe if you go to the next slide and then come back to this, maybe it solved the problem. No, so you have to basically just be mindful that we don't see some of the parts of your slides.
Oh, of course. Thank you for letting me know. So one of the quotes that I pulled from my experiences was a patient who said, I'm struggling to come up with counter statements. What kind of ones did you use? So yeah, firstly, this was a patient who understood the technique of counter statements, which she learned during her CBT sessions with her audiologist. But a few days later, when it comes to kind of putting that knowledge into practice, you know, a few days might have passed or life has happened and it might not be as fresh in their memory. So sometimes all that patient might need, which is what we offered, was to hear some real life examples from me. You know, oh gosh, yes, I understand. What I thought was, you know, this was my counter statement for this scenario, and you know, this kind of fulfilled all of the requirements of a counter statement. Here's mine, and I would offer my personal examples, and that can kind of prompt a patient into remembering how to build their own counter statements. You know, that was always a very useful kind of back and forth that patients would find kind of prompted them, just gave them a nudge in the right direction to kind of turn back to the knowledge that they had stored in there. But like I say, life happens, so many things can be going on. So sometimes a little reminder is all a patient needs. The next quote says, I don't have a session for a few weeks and I'm not sure how I will cope with that gap. And this is a scenario that all of our patients will come to. Our sessions, CBT sessions, this is, are staggered eventually. So their sessions will go from weekly to then be arranged fortnightly and then monthly. The gaps in between increase. And this can be a really daunting situation, especially when you feel there is progress happening and momentum. You don't want to lose that momentum. Yeah, it can be daunting. But actually, that's exactly, you know, why those gaps are there, how the program has been designed, so that you can have real world experience of putting everything you've learned into practice independently, seeing and feeling the effects and, you know, noting them as directed. So knowing that even though there might be a month before you next see your dedicated specialist, you can have a support session kind of in that gap, where, you know, it can be a comfort to still have a conversation about their techniques and their tools and how they're feeling, but it still gives the patient that crucial independence to put everything into practice that they've learned. And lastly, not sure if maybe this is one that you can't see on the screen, and it says, I want to speak to my colleagues about misophonia, but I don't know what to say. And this is, you know, we can swap out the word colleagues there for friends, family, boyfriend, wife. It's a situation where my experience as someone who has learned to effectively manage misophonia really can come into play, in that I've likely faced a similar situation. And obviously no two persons' experience is exactly the same, but there is overlap in terms of suggesting approaches for those really tricky situations. You know, these support sessions can sometimes become like a safe space for navigating hard conversations or discussions, trying out how you feel confidently talking to someone about your misophonia or your tinnitus and hyperacusis. And yeah, this was a conversation with a patient who just couldn't imagine finding the words, but through the course of their program, their treatment plan, they learn about their misophonia through the education sessions, which we'll hear about in today's webinar, and they gain that confidence and can kind of practice with me and feel ready to kind of face that conversation, which beforehand had felt so daunting. So yeah, these three examples are just a snapshot. Like I say, the conversations can take many different directions and be really rewarding for the patient and for us as we kind of see their progress and how much they've learned and how positive they are feeling as they move through the treatment. So that concludes my presentation. Thank you so much for listening. And yeah, I look forward to answering questions at the end when we have our Q&A.
Thank you very much, Becky. Fantastic presentation. I'm sorry from the audience and viewers that the actual slides, we could not see some of it. And but thank you, Becky, for going over them and explaining them properly. So although we could not see everything, but we
No
could
problem.
clearly understand. I hope everyone understood this. We have another fantastic question that is being posted from a person with severe hyperacusis himself, and asking, saying that maybe a contributing factor to stress in some people's life with misophonia and hyperacusis or even tinnitus is that they may not be able to also organize their life properly. And certainly this is a problem for him, that being unable to organize his life properly is adding the stress and exhaustion to him, making him less able to cope with the noises. And what is the support available beyond the therapy for people who may have such problems? Very good question, and thank you very much. And we are going to discuss that in the Q&A. Maybe Sherry with some occupational therapy ideas can help can help you, the owner of this question. But now, ladies and gentlemen, fasten your seatbelts. We are going to listen to a presentation about misophonia education. And these materials that Mercedes shares with patients are highly technical and scientific information, so it's not good for the faint-hearted. And we're going to see how she actually changed them into a digestible, easy to understand information that we all can benefit. Thank you, Mercedes. Go ahead.
Thank you. Hi, everyone. Can you see my slides?
Mercedes, I can't hear you very well at the moment.
Can you hear me now?
No. Very quiet, your voice is.
Can you hear me now?
Very quiet, very, very faint.
What about now? What about now?
Is that the microphone from your computer that you're using at the moment?
Actually, I did check and it was fine, but let me leave the meeting and I'll be right back. Sorry about that.
Yes, I hardly can hear you. So I think Mercedes had to restart her computer and she will rejoin us. And let's see if it works.
Let me check. Can you hear me about now?
No, it's very, very soft. Your voice is, I hardly can hear it.
Okay, give me a sec. Possibly using headphone would help.
Mercedes, do you want us to go to a different presentation for you to sort out that? And then perfect. I don't want to go to Q&A because I want all of the questions to be posted so we can have a lively Q&A session. And make sure to post your questions as we go so you can we can have a quick time to read them and make sure that who the question is for. We have several questions so far. Post your questions. Okay, so let me see who is in the program. Evelyn. Evelyn, are you ready to go ahead with yours?
Yes, sure. So are you able to hear me?
I can hear you, yes.
Okay, great. So just make sure that works.
Yes,
Okay.
I can hear you. Let me give you a bit of introduction. So we talked about CBT and the challenges. Obviously, CBT also is a costly intervention because it takes a lot of time of people who had many years of experience in helping patients, and a lot of training is involved. And but what is there a more cost-effective way of giving people this very much evidence-based intervention? And Evelyn is going to talk about self-help CBT and a guided self-help CBT. Thank you, Evelyn. Go ahead, please.
Thank you. Okay, are you able to see my PowerPoint?
Yeah, is okay.
Okay, great. Okay, so first of all, thank you very much. And hello, everyone. I'm going to introduce you the online CBT. So it is, as Hashir mentioned, a guided self-help CBT program for our patients. So online CBT combined with connection support has been proved to be as effective as traditional face-to-face CBT. And it was recommended by the National Institute for Health and Care in the year 2020. But however, a lot of the NHS trusts and private clinics may not be able to offer this to their patients due to limited resources or expertise or infrastructure. And what is QuietMind? It is indeed a treatment package combining the iCBT, the online CBT, and support sessions with our team. It is cost-effective, evidence-based, and easily accessible. So QuietMind is actually the service for our partners. For audiology departments, NHS or private sectors, we have this partnership program which we can provide guided iCBT to patients on their behalf. It can benefit the departments to add CBT into their usual therapy package, especially for those with long waiting lists. And how does it work? So once the patient registers for the program through their audiology departments or clinics, we will contact the patient to set up the first support session through a video call. The patient will start the online assessment followed by reading the modules. Before or after each module, we will have a support session with the patient to make sure that they understand the materials and complete the assignments as required by each module. And after finishing all the modules, the patient will complete the final assessment. We'll then review from the final report to see if further intervention is needed. And now I would like to share some of the research results done for the iCBT program. This study was published in the Journal of the American Academy of Audiology in the year 2023. The first graph shows the first measurement, which is the 4C Tinnitus Management Questionnaire. The higher score is 100, and the higher the score, the more confident the patient is to manage their tinnitus. The blue bar is the score before the iCBT program, and the orange bar is after. The 4C scores improved significantly after the treatment. And the second graph shows the SAD-T. The scores reduced significantly after the treatment, which means the anxiety and depression symptoms are less. And lastly, I would like to share some feedback from a couple of our iCBT patients. The first patient mentioned before the treatment that, do I continue life as normal with constant audio distractions, or do I allow more and more silence in life? So the dilemma the first patient had is whether to use distraction techniques or going down the route to accept his tinnitus. His 4C assessment score increased after the treatment, meaning that he gained a higher level of confidence managing his tinnitus. The program has also clarified him regarding his dilemma. So after the treatment, now he said, I have stopped catastrophizing my negative emotions. I can see that the true effects of tinnitus on my life is less than what I anticipated. I do not need to be dependent on background noise. And here is the second patient. She mentioned before the treatment that I feel trapped in my own head and worry that tinnitus will get worse when I get older, and worry that I have no control over it at all. Her FOSI score reached 100 after the treatment, meaning that she was very confident managing her tinnitus. And now, after the treatment, she mentioned that if I'm annoyed by tinnitus when reading or falling asleep, now I know how to modify my negative thoughts and don't get upset. So that is my presentation, and thank you for listening.
Thank you very much, Evelyn. And if you have questions about the QuietMind or ICBT guided program, if you're an audiologist that you might like to have this for your service, or if your patients would like to access this, please post your question now, and then we will answer them in the Q&A session. And so we are going to the presentation by Sherry, who is an occupational therapist and helping people with sound sensitivities and sometimes even people with tinnitus as a part of their treatment. And so these are the patients who are already taking CBT focused on their condition. They're also seeing our clinical psychologists and health psychologists and so on. And but they still may be struggling in understanding the concept and using the CBT methods, and which require a lot of practice. But in the meantime, the OT intervention can actually help. But how? Let's listen to Sherry.
Hello, everyone, and thank you very much, Hashir, for the introduction. Okay, let me share my screen. Sorry, okay. Share. Okay. Right. Okay. My talk today is about how occupational therapists can help children with misophonia and who have sensory processing disorders. Sensory processing disorder is difficulty with organizing and responding to information that comes from our senses. It can be auditory or touch or vestibular. Some of the children, they are sensitive to taste and smell. Children or adults with sensory processing disorder find some specific sensation distressing and unpleasant, like children with misophonia, that they don't like specific noises. These children are oversensitive to certain sensation. As I said, it can be kind of touch, or it can be noise, or some of them, they have sensitivity to movement. We see some vestibular problem in those children. Oversensitivity to any of this stimulation can cause emotional dysregulation or anxiety, and they can kind of present with sensory avoiding behavior. And we usually kind of see in children with misophonia, they tend to leave the table, or they cannot tolerate social interactions. Many children with misophonia may have additional diagnoses like autism or additional deficit hyperactivity, ADHD, and these are kind of the main areas that OTs, they can help. In terms of the assessment, we have three names of the assessment for sensory issues or sensory processing difficulties. We use a sensory profile questionnaire. We have two different versions, one for the school environment and one for home environment, because majority of children with sensory processing disorder, they show different behavior or different social emotional reaction in different environment. For example, the home environment can be quite controlled, or the school environment can be kind of, because they need to follow the rules. Then depends on the environment and then how they perceive the sensory stimulation, they would react differently. Then we have two different types of questionnaire to compare and see how these sensory processing difficulties impact on the emotion and behavior. Then we do clinical observation, and we have interview with parents and teaching staff at the school to see how the sensory processing disorders impact on the child's function and social interaction. Then when we do the assessment, parents and teachers, they tell us more about the behavior. Then the behavior is going to be kind of the main red flag for us to see whether the child has any sensory processing difficulties or not. Then we see two different types of behavior. Then it's either the sensation seeking or sensory avoiding behavior. Then sensation seeking behavior is fidgeting. Then, you know, the child sitting in front of TV, or the child is in a class and they tend to rock on a chair constantly. They sit like that and press the chin. Some of them, they have kind of a bit more extreme behavior like head banging or biting when they get frustrated. When they want to hug others, they don't know how much pressure they need to apply. They hug their parents or friends really hard and tight. They tend to rub their hands or flapping hands. They are on a go, they run around. If they are in a class, they constantly stand up and sitting. If they are reading, you know, then we see kind of, they tend to fidget quite a lot. They tend to, some of them, they tend to smell non-food objects, you know, like a blue tag or a piece of paper. As a result of kind of the triggers, whether it's a noise or is it a touch or is it a movement, they have sensory avoiding behavior. And the sensation avoiding is you see that the child is quite agitated. They have poor attention or short attention span. When it comes to the noise, they tend to cover their ears. For some of the children that they have some visual sensory processing difficulty, they tend to stare at the objects and they look at the objects really carefully. And humming is one of the other problem. Because they want to block the background noises, they tend to hum. Some of them, they talk quite a lot. I mean, for example, they are doing some writing or doing maths, they constantly to talk to themselves. It's a self-talk behavior. They show avoidant movement experience. They don't enjoy physical activities. They tend to avoid it, PE or sports. Some of them, they have sensitivity to touch. They don't like messy activities. They tend to wash their hands quickly. They feel kind of like quite frustrated when they touch a sticky or a slime or any kind of objects like that. They find difficulty with transition. Then if they, for example, if they are playing with something, then moving on from one activity and start something else, it's very hard for them. Some of them, they are tiptoe walkers, or they have sensitivity to clothes. Then, you know, it doesn't really matter whether it's winter, but they usually kind of want to wear shorts or shorter sleeves, or they are sensitive to uniform, school uniform. They don't like socks. These are kind of the additional kind of sensory processing problem to kind of misophonia if they have sensory processing as well. Then the most important part of the learning from the occupational point of view is to help the child to self-regulate. Then the first picture is about kind of playing in a beach. You know, children with sensory processing difficulties or noise sensitivity, sometimes playing outside is very hard for them because some of the environment like beach is very noisy, is going to be very busy with lots of movement, people, it's very crowded. Then for them to be able to register all this information and process the information is very hard, and then they can kind of get frustrated or they can tolerate it for a short period of time. Then some of the children, they are messy eaters or they are picky eaters, then it's very important. We have a specific program to help them. If it's about the noise, crunch or kind of loud noises, either misophonia or hyperacusis, then we work on the emotional side of the problem to help them to manage. and participate in social activities. From the occupational perspective, there are two main interventions. One of them is sensory integration approach. Then we have we use lots of strategies, and we teach children lots of strategies to manage and cope with the sensory problems. And the other program, which is focused on managing the emotion, is a zone of regulation. This program specifically has been designed for children with autism and ADHD, but we have been kind of using it quite a lot at the schools and for children with misophonia, that they may find CBT, the very comprehensive program of CBT, might be difficult for them. This program has been created to teach children to communicate their own emotion and manage sensory difficulties. This program categorized emotion into 4 zones. As you see, we put them kind of in blue zones, green zones, yellow zones, and red zones. And each zone reflects on a specific emotions. Blue zone is all about more kind of passive emotion, sad, sickness, being sick or tired, bored, or the child is just kind of feel passive or doesn't kind of feel to participate in any activity. The green zone is the zone that we always kind of try to take the child to this zone, because it's a zone that we are ready to learn, we can focus, and we feel okay. We always kind of say green zone is not just about being happy, but it's the zone that the child is able to cope with the sensory triggers and to be able to focus. The yellow zone is a trigger zone, the zone that the child is going to be edgy or very frustrated, and the green zone and the red zone is when the child is very angry or because of that specific sensory issues, cannot tolerate the environment. They want to get out of the kind of the room, specifically for children with misophonia. They cannot tolerate to sit at a table with a family, and then they get very frustrated. The key component of zone is more about, as I said, it's based on the cognitive behavioral therapy, but it uses simple language to discuss about emotion, thinking process, sensory needs, and environments, and then how all this can impact onto any of these zones. Then we talk through all these kind of stages, and the children, they need to be able to reflect on the emotion. Then, as you know, children with sensory processing disorder or ADHD or ASD, they may find understanding their emotion and other people emotion hard. Then it's a very kind of visual and simple program to go through all this emotion with them. It's very easy to talk about the social perspective, and we break the social perspective to smaller steps to teach them. And we talk about sensory strategies and calming strategies, and teach the child to understand their sensory needs and solve the problem, rather than showing avoidance behavior. Talking about the sensory strategies and calming techniques, then we look at kind of 2 different things. One, environmental adaptation, and the other is sensory strategies. Then if, at home, then we recommend lots of kind of adaptation to help them to calm themselves. Then it can be the low light, using very calming colors like blue or green lights or colors, using very soft and slow speech. Then make sure that the room or the desk in the class that they're using is not cluttered with lots of bits and pieces, because it's going to impact on the children that they have visual sensitivities. We recommend at the school or at home for parents and teachers to set up a quiet corner we recommend rocking chairs then because it's very calming. Then you know, some of the children with autism and ADHD then they tend to rock quite a lot on a chair. And the reason is that, you know, they're sending a message to brain that I want to become calmer, and that's why they start kind of rocking on a chair. In terms of these strategies for children that they find sleeping at night, we recommend weighted blanket. Any deep pressure on joints like crunching, crunchy food or chewy tube, then we recommend a chewy tube. Then it's very calming for them. Calming music or repetitive music, it can be very calming. Linear movement is impact, kind of any movement like back and forth. It can be on a swing or on a therapy board. It's very calming. And then use the weighted jacket or tight jacket, and we have a specific program for using the weighted vest or tight jackets that they need to wear it for 20 minutes every 2 hours, and it's going to send the message to the brain and say the body needs to calm down, and also kind of send a message to limbic system to help with managing the emotion. And these are the equipments that we usually kind of use for children, a weighted jacket or bear hug. Then we recommend heavy snake or heavy lap that they can use in a class. Hockey stool or busy legs, because for children that they tend to rock on a chair, but it's not really kind of practical, and some of the children, they don't like it at all. Then we recommend busy legs, fidget toys. Then if you remember about the Joanna's lecture, then she was mentioning about kind of observing some physical reaction in a session, and the child was fidgeting. Then we recommend fidget toys, and also kind of movement seat cushion. And for some of the children that they tend to move a lot on a chair, then we recommend movement seat cushion, and also kind of weighted blanket. Then these are the kind of the main strategies that we usually kind of use, and in addition to emotional regulation program. Yes, that is the end of my presentation. I'm so glad that you listened to my presentation, and yeah, lovely. Thank you very much.
Perfect. Thank you very much, Sherry. And so let's have another let's see if Mercedes sorted her.
So can you hear me?
I can hear you, yes.
Okay, fantastic.
Go ahead,
Sorry
please.
for the
Sabrina.
hiccup. I think this is the danger
I
of...
have already introduced your presentation.
Okay, lovely.
Do it again. So people, please remember, try to recall what I said before Mercedes' presentation. Go ahead, Mercedes.
Okay, yeah, sure. So you should be able to see my slides now, right? Cool. So hello again, and good day, and sorry for the hiccup. I'm Mercedes Irfanian, a neuroscientist and a research fellow at Hashir International. So I study various characteristics of tinnitus, hyperacusis, and misophonia as a part of Hashir treatment protocol. I discuss with patients what neuroscience has revealed about the brain basis of misophonia that I'm obviously going to be talking about today. So the human brain is made up of about 82 to 85 billion neurons, which are like worker bees. These neurons communicate with each other to make the brain work properly. When they send signals to each other, they create electromagnetic fields around the scalp that can be detected by very strong devices like EEG or electroencephalography with a lot of sensors on the scalp. If there is something wrong or abnormal in the brain, these brain waves can show it. Of course, not in all cases, but in most cases. Researchers discovered that some parts of the brain waves in people with misophonia are different from people without misophonia, specifically when they listen to a random beeping sounds. Of course, this random beeping sound is called oddball test that I'm not going to be talking about today. This difference in the brain waves is also seen in other disorders, such as schizophrenia with auditory issues, bipolar disorder, PTSD or post-traumatic stress disorder, and so on. These results suggest that people with misophonia may have problems in early auditory processing, given sounds are processed via different stages in human brain, including early, which obviously happens as soon as the sound impulses reach the brain or central nervous system, and later stages, which are different in time. So the fight or flight response is our body's natural reaction to danger or stressful situations. When we sense a threat, like a lion chasing us, our body prepares to either fight the danger or run away from it. This response involves various physiological or physical changes like increased heart rate, quick breathing, sweating, or boost in energy that all help us react as quick as possible to survive in a dangerous situation. A couple of studies found that when people with misophonia hear the sounds that bother them, their fight or flight response kicks in. It's worth noting that these body changes aren't always noticeable and may require, again, special devices to detect. According to these studies, when people with misophonia hear irritating sounds like chewing, they may feel their heart pounding as if they are in dangerous or a stressful situation. An increase in heart rate can also cause sweat glands to become more active. In more severe cases, people may experience excessive sweating, especially if they have severe misophonia. This explains why sufferers either flee from or they have this tendency to flee from the situations with triggers in it or exhibit verbal or physical aggression, albeit in some cases, not all cases. So before talking about more of the brain basis of misophonia, I need to explain two different terms that will come handy very soon. The first one is a structural abnormality, and the second one is functional abnormality. A structural abnormality in the brain means there is a physical difference or tissue in how the brain is built or organized. It could be a change in the size or shape or connections of the brain's parts. This physical difference obviously can impact how the brain functions, which may affect a person's thoughts, emotions, or behavior, which is known as functional abnormality. When we talk about functional abnormality, we always refer to hyperactivation or hypoactivation. Hyperactivation means the brain works more than usual, like being in overdrive. On the other hand, hypoactivation means the brain is less active than it should be, kind of like taking a break when it shouldn't. These changes can happen due to various disorders or conditions that can influence how we think, feel, or behave. So a few studies looked whether there are functional and or structural abnormalities in the brain of people suffering from misophonia, in which this suggests that when people with misophonia listen to misophonic sounds or misophonic triggers, some brain parts get overactivated that does not happen in people without misophonia. One of these main parts is called anterior insular cortex, or AIC, that you can see in the picture. Anterior insular cortex is responsible for processing emotions, interception, saliency, and many more. So saliency means perception of stimuli in the environment that stands out, like the sound of ambulance siren that sticks out from other sounds among all sounds in the busy street. This suggests that individuals with misophonia find certain sounds like chewing particularly noticeable. They react to these sounds because these sounds or these sound often grab their attention and basically pushes them to react as quickly as possible. That's why they flee. That's why they might block their ears or show other types of coping mechanisms or behaviors. So interoception is like our body's internal sense. It is how we feel, understand, and perceive what's happening inside ourselves, like sensing if you're hungry, tired, or have a fast heartbeat. It helps us recognize and respond to our body's signals, sort of like tuning into our own physical sensations. This may explain why individuals with misophonia have a heightened focus on their bodily changes, such as increased heart rate when exposed to sounds that make the misophonic experience even more unpleasant. So besides all this functional abnormality like overactivation of anterior insular cortex, these studies also found that some brain parts are abnormally overconnected, which can give rise to misophonic experiences. So the example of overconnection would be a light switch, as you can see in the image. The light switch represents a sound trigger, which leads to activation of certain region or network in the brain in non-misophonic. For example, when non-misophonic listen to a sound, their auditory cortex or the hearing part of the brain activates because it is processing all the sounds or all the vibration that is going into the ear and then reach the brain. However, in misophonics, the sound trigger causes the activity of several unrelated and unnecessary brain regions. Like you just enter your house, you turn on the light of the hallway, and all appliances and all lights in the house turn on, which is not necessary, and it's also unrelated. So these over-connected brain parts are responsible for creating and storing memories, that is called hippocampus, generating our emotions like amygdala, and high brain functions like attention, control, and many more. So when anterior insular cortex, or the part that is responsible for processing emotion, saliency, and interception, get overactivated, it signals a lot of unnecessary and too many signals to those other parts of the brain. And it causes a lot of issues in attention, maybe causing too much attention to misophonic sounds or creating negative emotions. These findings suggest that when people with misophonia, or misophonic brain I would call it, detects a noticeable sound like chewing, it sends signals to other parts of the brain that generate emotions such as anger, and it also creates memory linked to those sounds, like associating a colleague that once made one of the triggers. And this may also lead to getting overly focused on the sound, making it very, very difficult to separate from, or even difficult to control the emotions associated with those sounds. Now, I'm pretty sure you're asking yourself, why these very specific sounds? Why not other sounds? So this is what we actually tested back in 2022. It was a collaboration of University College London and University of Newcastle. So we looked at other parts of the brain beside anterior insular cortex and hippocampus, amygdala, and so on. So we were interested if there are functional and structural abnormalities that I have already mentioned what they are in other parts of the brain. We were also interested if there were differences in brain of misophonic versus brain of non-misophonic, but they were not even listening to any of those triggers. Our results show that the brain region responsible for processing information coming from our eyes and our ears were overconnected with the brain region that is responsible for interpretation of all our senses and our movements. In particular, the movement part was the part that was responsible for the movement of our mouth and nose, what we call it orofacial movements. In addition, we found that hearing part of the brain and movement were overconnected. And also movement region was overactivated while people with misophonia were hearing the misophonic sounds. Altogether, these results suggest that when individuals with misophonia hear their triggers, the part of the brain associated with movement become active. This isn't very typical in normal situation, as I said before. And they may even mimic the sound because it's as if somebody's directly stimulating the movement part. But this is done via sounds. It is very similar situation to when we yawn once we see somebody else's yawn. So to sum up, through the studies looking at the brain of misophonic sufferers, we learned that several parts of the brain work and shape differently in comparison with people without misophonia. These differences underlie the emotional, cognitive, and behavioral characteristics observed in misophonia. However, I should mention here that we have a long way to understand the true nature of the misophonia. Thank you so much for your attention.
Thank you, Mercedes, for giving a snapshot of what happens in a misophonia education session, which Mercedes does these sessions for patients with misophonia, and Imke, who is another neuroscientist, does that for patients who have tinnitus and or hyperacusis. And so I hope you enjoyed the presentations. I invite back all of the panel members to turn on their camera, and so we can go through some of the questions. Becky, do you want to start reading out and we alternate, you and I?
Yes, of course. So we've got a question here for Patricia from Amy, who asks, what do you do if the patient finds some proof in their beliefs and uses this over the proof they achieve in the exposure activity? For example, they believe they will feel 100% and they do consistently. I understand this is extremely difficult. Thank you.
Yeah, that's a really good question. Thank you for that. In this scenario, what I would do is I'd work with the patient to explore and challenge what precisely they believed to be proof. And also, I'd explore what else can be true at the same time. I'd also examine the fact that even though they scored 100%, the fact that they've got a score proves that they've actually completed the task, even with tinnitus being present. And so in doing that, they've increased or proved their tolerance to the tinnitus. After we've had that discussion, I might suggest repeating the exact same cell with that new knowledge and see what the next week gave us to work with.
Thank you. I also just like to add to this, because it's a very interesting question, that you have to go back to the theory of cognitive theory of Aaron Beck. So this is the question. The problem that we're facing is that when human beings are under stress or feeling anxious or feeling afraid, there will be an increased cognitive errors within our brain. So we have a lot of errors of judgment, and one of those will be exaggeration or predictions of the future and so on. And these are errors according to cognitive theory. These are errors of thinking. So we may catastrophize something, and we do that much more. These errors always exist, part of being a human, but they increase significantly when we are under stress or anxious or afraid of something. And so CBT wants to provide this opportunity of experimentation. So the person first identify those thoughts. They may not recognize them as error, but then provide this unbiased, objective way of assessment of whether these are true or not. Yes, of course, sometimes that objective assessment may not be possible, but as Trish said, gradually over time, people learn to become more objective and be more critical to those errors of judgment, as opposed to just accepting them as literal facts. But it's a process that the person needs to go through and learn and gain these skills. And so I read a question from a person who has hyperacusis. Joanna, they are talking about Dottie's problem, and they think that one of the problems that Dottie may have is because they're not very organized in what they do, and they may be struggling to organize their life. So the question is, organization of environment is a massive problem in my case. This is a person who have hyperacusis themselves. Do people need more than CBT? And they think yes. And so with so much time devoted to managing clinical disorder, how can patients live alone or ever get an organized life? And I don't know if you want to comment on this.
Yeah, so that's obviously why we have a multidisciplinary approach, so that if we don't have the time to go over other factors that could be beneficial to the patient because we're working on sort of clinical work, we have Rebecca, who's the patient support officer, who would be able to sort of discuss other sort of things they might be able to put in place, and Sherry, who might be able to look at sort of other sort of sensory issues and sort of getting some organization or sort of ways that they can manage. But in this case with Dottie, obviously she wasn't living alone. She did have her mum there to support her, who was a massive help. And the diary, when we were sort of working through the diary, it gave us a real sort of highlight of where we needed to work on. And so we did discuss that in the appointment as well as the clinical side of it. So we were able to say, right, okay, actually in the morning, triggers are much worse. Why are they much worse? When we were doing our question and evaluating answers, other because actually Dottie wants to be on her tablet and she wants to be playing games rather than getting ready for school, and this then stresses her out, and then she doesn't manage triggers very well, so then that creates more stress, and then she isn't able to get into the routine of being able to get ready for school. So actually recognizing this within the diary work that we did, Mum and Dottie were able to then put in place, right, okay, in the morning, this is what you do when you get up, and then you can have some time for your tablet if there is time left over. Dottie isn't stressed and she's not triggered as much.
Thank you, Joanna. Sherry, do you like to add anything?
Yes, I mean, in terms of the organization, because children with kind of people with the sensory processing difficulties, they have a problem with the executive function, and organization skill is part of that. Then when it comes to children, there are kind of, as Joanna mentioned, kind of diary is the main thing, but the OTs look into the daily routine and breaking the task down. And then we talk about the visual and time and pacing for the child, that how long kind of that activity that he wants to do takes time. And then we go through all this process, and and then lots of kind of visuals, or there are lots of apps that can help with the organization skills. And we talk about lots of different strategies by looking at the child daily routine.
Thank you very much.
Looks like we have a question here from Mary, who asks, is there any link between these conditions and a hypothyroidism and or celiac disease? Hashir, maybe you're best to direct this towards one of the team members.
Yes, I think a thyroid function has some relations with tinnitus, but it's not a one-to-one relationship. So some people have reported the thyroid problems that's as a side effect, or even side effect of medications they're taking for that. Tinnitus could be there, but majority of people who have tinnitus, they may not have any thyroid problem whatsoever. And so we are not 100% sure. I don't know if Mercedes has heard anything or read anything about thyroid function and misophonia.
And I have never heard, and I'm pretty sure there is no evidence-based research in that regard.
So it's something for researchers to study in the future to be able to answer that question. Mary asked another question. Mercedes, maybe you'd like to comment on this, that if there is any link between misophonia and autism.
Oh, yes. There are actually tons of research out there showing that the prevalence of misophonia in kids with autism, ASD in general, autism spectrum disorder, ADHD, and Asperger's syndrome is relatively high, but we really don't know exactly if just kids or adults with autism spectrum disorder or the symptoms of ASD would suffer from misophonia or symptoms of misophonia or misophonia traits. This is not really well known because at the moment, we recognize misophonia as a self-standing disorder. So it means that it should not emerge with the basically overlapping and comorbid disorders. It could be comorbid, but the symptoms should be independent from other similar disorders.
So not everyone with misophonia have
That is correct.
autism.
Yeah, but
And,
comorbidity is relatively high.
they also ask about the effectiveness of treatment. Sherry, do you want to comment on this? Like if they have autism, like what are they, because you get involved in their treatment. Any comment on this?
Then I think when it comes kind of to children with autism, we need to look at the cognitive ability of children with autism, because some of them, they are high functioning autism and they easily can participate in the CBT program that Hashir and your colleagues can provide. But sometimes it's not just kind of the problem specifically with misophonia. The child has high level of anxiety or avoidance behavior in addition to other sensory issues. They have misophonia and kind of additional kind of problems. And then, and this is the time that the OT is going to help quite a lot, because the zone of regulation, the emotional regulation that we have, it's kind of works really well with your program, but we make it kind of more child-friendly and very visual, because children with autism, they learn emotional skills through the lots of visuals and kind of breaking the kind of the explanation to kind of simpler language. Then I've had kind of children with misophonia that they have autism, and the program and kind of working as a team with your audiologist, then I think we had quite a good results. Did I answer your question?
Thank you. Yes, and often when, depending on the severity of these conditions, our clinical psychologists and even a psychiatrist need to be involved to make sure that they receive all of the needs that they have are addressed and are.
Sorry, Hashir, I need to add something else. We have added a review of one of the relatively recent studies that has been published by Amsterdam Medical Center Group. They actually look at the genetic components of symptoms of misophonia with other comorbid disorders, and they found negative correlation between ASD genetic basis and misophonia. So this is something that you would possibly like to consider, and you can find it in our website if you want to.
So that's basically going on the direction that there may not be really a fundamental link between the two.
Exactly.
And thank you for adding an updated research update. So Becky, is that your turn to read the question?
Yeah, we have a question from Mary who asks, does CBT work just as well via online as face-to-face? I think we can all add to this. From my perspective as someone who's gone through the treatment program, the simple answer is yes, it's very effective online. There's many benefits to it in terms of flexibility, being in the comfort of your own home. Obviously, not having to commute somewhere can mean that you get more time to independently, reflect on your sessions, go through the tools and the techniques. That's more of a logistical thing. But in terms of getting a connection with your specialist, even though it's online, it's still a very, very strong connection. And you know, we've all become so experienced and practiced at how to adapt our techniques to the online world, and it means that we can reach anyone wherever they are in the world, which is a wonderful attribute to have. That's my perspective. I didn't know if anybody wanted to add on that.
Joanna,
Yeah,
go ahead,
could I,
please.
yeah, as a practitioner for myself, I find it really effective doing sessions online, and I actually feel more comfortable doing sessions online than when I do sessions face to face, just because I do see a lot of patients who do have misophonia and hyperacusis, and I find actually doing the session online, there's obviously a physical distance between yourselves, and you're not actually, the patient feels more comfortable because they're not being triggered by you or somebody else that might be in the room. If they have hyperacusis, they might not actually want to attend an environment where they have to sit in a waiting area. So all of these factors tend to make it more comfortable for myself, first of all, but also the patient.
Thank you, Joanna. And there's a question from Amy. Do you feel background noise or sound should be avoided completely, as it is seen as avoidance behavior rather than intervention? And I noticed Evelyn patients, example, both are unsure about using sound or trying to accept silence environments. And so you are right, Amy. Sound or using background noise to mask tinnitus or distract yourself from tinnitus is considered as an avoidance behavior. And although it can be useful in the short term to be distracted from tinnitus, but it doesn't address the underlying anxiety. And in most cases, it will backfire in the long run. So in CBT, that is considered as something, as a behavior that the person needs to prepare and gradually reduce if they are already dependent on it. And there's another question from Amy as a follow-up on this. This is for Evelyn. Is the ICBT person-led or purely content, or is it is people are helped with someone?
Okay, so I'm going to answer this question. I would say it's actually a combination because ICBT for the patients, they also have to read the materials online by themselves. So it also requires quite a high level of self-motivation. But at the same time, because it's combined with the support session, so when the patient's having support session with one of our expertise, then we will make sure that they really go through the progress and understand the materials, and as well as complete the assignment, because that also give us I would say like a signal that they do understand the materials, then we'll be able to move on to the next module. So I would say it's a combination of both.
Thank you.
Wonderful. So we have another question here. How can an audiologist differentiate misophonia from hyperacusis?
Maybe Trish, do you want to answer this one for us? Thank you.
So the definitions of misophonia and hyperacusis are slightly different. So hyperacusis is an intolerance of loud sounds that other people can tolerate perfectly well. Misophonia is an intense emotional reaction. So maybe rage, for example, or disgust in response to bodily noises. So mouth, nose noises, sniffing, swallowing, eating, chewing. It could be even tapping or foot swinging or something like that. So the reaction is something that comes from, yes, it's still sound, but the definition is misophonia. The sounds are created by another person. Hyperacusis, you're talking more about things like doors slamming, people bouncing balls, traffic, that kind of thing. And we have also got the standardized questionnaires that help us to distinguish between hyperacusis, misophonia, noise impact, different types of sound sensitivities. So, you know, we come to our conclusion after quite an in-depth interview and you know, quite a lot of questionnaires to really get to the bottom of what it is exactly the person is experiencing. So yeah, there's a lot of effort that goes into the distinctions.
Yes, yes. And so there's no audiological test can distinguish these two from one another reliably. But as Trish said, you know, it is the gold standard for this differential diagnosis is the clinical interview that is done, and it's quite time. It's usually about an hour or so to actually get to the bottom of this. Thank you, Trish. So a question for Sherry. What age do children start to display the sensation-seeking or avoidance behaviors?
In terms of the standardized assessment, the sensory profile questionnaire then start from birth to we have an infant and toddler assessment questionnaire. Then we can kind of assess children from birth up to 6 months and 6 months to 3 years old. And then the clinical observation, then occupational therapists with sensory integration training, they can observe infants to see whether they present with a sensory seeking behavior. Then one of the main sensory seeking behavior for infants that they are very agitated, they don't have a good sleep. And then when, you know, when they are 6 months, to my experience, it's very kind of, it is much more obvious at age 6 months to observe the sensory seeking behavior. There is a feeding issues that we definitely see. A sleeping problem can be a sign of that. And they have a problem with the breastfeeding. They don't tend to latch, and then that's a main problem. Then definitely we can kind of see this sensory seeking behavior from infants and toddler age.
Thank you, Sherry. We've got a question here who says, really interesting, Mercedes, so that's directed towards you. Has this reaction been found or can be transferred to hyperacusis or tinnitus patients? So I guess transferring that misophonia reaction. And does this overreaction, or overconnection, change the way we should provide intervention?
Yeah, actually, I thought about it. That's a good question. I think majority of the behavioral or the coping strategies that people suffering from misophonia show would be more similar to hyperacusis rather than tinnitus. But obviously the perception is different. And also, I'm not 100% sure if the emotions are different. The most dominant emotion that people with misophonia show would be anger, irritation, and less of anxiety. And this anxiety could be emerged when people anticipate to be confronted with the trigger. But obviously, this is a different case with people suffering from with hyperacusis. And about the overreaction, overactivation, I guess this is what she meant. Overactivation and overconnection change the way that we should provide intervention. I'm not really sure, because misophonia is, as far as I have researched it, misophonia is more about the semantics of the sound, what that sound represents, what that sound is associated with, not necessarily the physical properties of the sound. I mean, physical properties would also contribute some way, somehow. We have learned through all this research we have done that it seems majority of these sounds, it doesn't matter if it is generated by human or it's coming from the environment, in it's organic and non-organic, they are repetitive and pattern-based. So we know that there is something in the physical properties of the sound, but it contributes less to the misophonic experiences in comparison with the semantics and everything that that sound represents. Given that there are a lot of research out there looking at the personality traits and different traits in general of people suffering from misophonia, we know that misophonia seem to be on the high end of perfectionism. They are very much against norm violation. They have the higher tendency to control their environment. So whatever that is unpredictable, unnecessary, and is not accepted by majority of people seem to trigger. For example, they might have this conversation, internal dialogue, when they're sitting in a tube, that why that person is, for example, unpacking a sandwich, and why that person, for example, eating an apple so loud, because it's not necessary, because it's not accepted. We know that when we eat something, we have to eat it with the mouth open. So these are all sorts of internal dialogue that the person with misophonia have. And also something else that University of Sussex has looked into, and we are actually running a study very soon to follow up. That component is the cognitive flexibility. It seems that people with misophonia are less flexible in comparison with people without misophonia, or less empathic in some components. That's why CBT can help them to open up, to look at the world from other people's perspective, to give meaning to what they do. Like, if the person is unpacking a sandwich in a tube, maybe that person doesn't have time anymore, and that's the only buffering time that the person can eat. So we automatically becoming more empathic, and it would obviously, as a result, affect the emotional and physiological response. I hope I answered the question.
Thank you, Mercedes. There's a question from Mike. Do you have experience with physically disabled people with chronic tinnitus and hyperacusis stemming from injury to spinal nerve roots? And well, for tinnitus and hyperacusis, there are a majority of the people we cannot really pinpoint where the exact cause of their tinnitus or hyperacusis is, and even if we do, either that cause is fixable or not. If it is not fixable and tinnitus remains and hyperacusis remains to be bothersome for the person, so the treatment protocol is exactly the same as other people, but obviously their personal circumstances have to be taken into consideration, and the type of professionals that will be involved in that treatment will also be different. There's this question about the QuietMind program, that whether it's an app or not. This is not an app. This is a therapy program. And if you are an audiologist, which I know, Susan, you are, and so this is a service that we do for other clinics who may not have the resources to provide CBT for tinnitus. If you would like to use this service for your patients, you can email us and we will answer the question. Back to you, Becky, please.
Thank you, Hashir. Yeah, we have a question here from Philippa, who asks, do these techniques help those with pain, hyperacusis so severe that they wear noise protection or housebound because of it and can't tolerate listening to speech or even the sound of their own voice? So I know we do have experience in this area. So Hashir, if you want to direct towards who's best to address this.
Trish, Becky, would you like, Joanna, would you like to go? Joanna, go ahead, please.
I saw a patient last year who had these exact symptoms. They were housebound, they were completely isolated, they couldn't tolerate the sound of their own voice, they couldn't work. We did online sessions and we did them via subtitles. So my volume, he could the patient could mute my volume, but I was speaking to the microphone. That would translate, and then the patient would type back to me their responses. So we managed to do treatment in that way. They are now still managing their pain hyperacusis, but they are working from home, so they are back to work. They're now able to take video calls, able to get out of the house, which was by when we did experiments, when we did the cell. It was a very slow process, but the patient was very engaged and determined to be able to live, go back to a life as normal as possible. So yes, this can be really beneficial.
So I do remember this particular case and similar patients, and it was much more challenging for us to basically, as Joanna said, she could not really talk to them and had to use subtitles instead, and that basically impacts on the dynamics of a session. But I think it worth it, and they were much better after all, and could go back to work, and we supported them throughout that process as well. About the research publications on materials that Mercedes discussed, we have, if you look at our website, there's a research hub, as well as under our resources, there's a misophonia information that you can see, and all of the information there and various different references are already there that you can visit. And I think the last question is for you, Mercedes. Do you want me
Yes,
to read it for you, or you have?
No, I can read it.
Yes,
Also,
okay.
about the previous question.
Mercedes, just because, sorry, because we're running out of time, so please answer this only with 1 minute.
Okay, sure. First of all, we are all available on the website. Feel free to also find my email there. Otherwise, feel free to email Hashir, and we can stay in touch. So about computational model, that's a great question. We have a bunch of studies. One of them, we actually collect data, and we are doing machine learning to understand the differences between the diagnosis of hyperacusis and misophonia. Hopefully, we are still analyzing the data. Hopefully, the paper will come out this year. And also, there is another research idea we have, but we need to obviously find a funding body in which we are going to be using AI. And through this, we will collect lots of misophonic triggers. And through these misophonic triggers, it's a pretty complicated study. I can't really answer it in 1 minute. But by using AI techniques, we would hope to basically come up with a solution to predict and to diagnose people with misophonia. I know this is not the most elaborate answer, but I'm happy to discuss this further via email or online calls. Thank you so much.
Perfect. Thank you very much, Mercedes. Yes, this was a question from Mohsen. And if you are interested in collaborating with us, please feel free to email us, and we put you in contact with Mercedes. And thank you very much for people who were listening. And thank you very much for our panel of specialists. And this is the end of this webinar. And I hope that you enjoy the various different programs in the National Tinnitus Awareness Week. Thank you.